psychologist. I'm involved in lots of different things, supporting now children and their parents in the process of coping and adjusting. But also I do lots and lots of things like staff training, service development, consultation, and lots of teaching. And after I was working in the community and I worked with lots of children and families with Duchenne, I took up a job setting up the psychology service for the Southwest Neuromuscular Operational Delivery Network, and I was the first psychologist in that post, which was really, really exciting. But the psychologist in the Southwest only covers adults, and in the Southwest we don't have paediatric psychology support, and that was my love. My love's always been working with families. So I left that post and took up a post in inpatient paediatric palliative care, which is what I do now. So I tend to work on the acute side of things, but I still work with families affected, living with Duchenne and things like spinal muscular atrophy and some of the rarer muscular dystrophies. I consider it an enormous privilege to work in this area. I love my job. I really, really can't tell you how much I love my job, because I get to meet people doing the most extraordinary things, and doing the most extraordinary things and having no real knowledge that they are doing the most extraordinary things. They're just doing their day, but it's extraordinary. And it shouldn't have to be. You shouldn't have to be extraordinary every day. And I'm so genuinely sad that life has thrown stuff at some of you, probably all of you, that's meant that you have to be extraordinary, because it would be nice to not, wouldn't it? But I feel honoured to be able to play a role in helping people to keep steady when the storms are thrown at them. And that's what I see psychology as being about. It's about helping you to stand and feel rooted even when there's a storm trying to push you over. So that's a bit about me and how I come at this. So I am going to talk about the psychosocial standards of care. And in them, they talk about transitions across the life course, and transitions are really important. As a psychologist, we talk a lot about transition. So they obviously talk about the transition from childhood to adolescence and adulthood, and alongside that, they talk about the transitions as the condition or the disease progresses. So they talk about, I don't know how many of you have read the original standards that were published in The Lancet. They talk about them as they go through each developmental stage. So that's how I'm going to do this. So we talk about diagnosis. They don't go into this level of detail, but they talk about families' needs at diagnosis, and they recognise, just something I've heard very strongly from the first workshop, that this is a family affair. And so they recognise that the whole family needs to be supported. They do point out, which I think is really important, the importance of clinics knowing how to manage in a crisis, which I've got to say I was really pleased to see acknowledged in the standards of care, because it's not my experience. One of the things I often get drawn into is if a parent expresses, for example, suicidal intent, the team feeling really unconfident in knowing how to support that parent for that time. Not just in terms of how to support them in the room, but also just knowing what services are out there and who would help. And then it doesn't talk about the other bits, but I'm going to. So in terms of the psychological needs at time of diagnosis, I think a key thing really is adjustment. And I'm going to talk very briefly about adjustment. For those of you who've just seen me talk for nearly 2 hours about adjustment, I'm really going to talk about it really briefly now. Information needs. Now this is important. So what is your coping style? So in terms of the psychosocial needs at the time of diagnosis, I think one of the most important things is recognizing how you cope. Are you somebody who needs lots of information? Are you somebody that needs to have less information and take more time? And really important is to feel confident in letting your medical team know that. Now, in other condition pathways where psychology is more embedded, oncology would be an example that comes to mind. I work in paediatric oncology. We have something called an integrated care meeting. So any child that comes in, and this doesn't happen everywhere nationally, it happens with us, but I think it happens in most places. When a child is diagnosed with an oncological diagnosis, they will be presented at an integrated care meeting. And in the integrated care meeting, you have physios, you have dietitians, you have the medics, you have psychology, you have speech and language therapy. And we all work together to think about that family and that child's needs, and to identify what help they might need, what information we need to better assess what help they might need, and to come up with a plan. This just doesn't happen in muscular dystrophy. It doesn't happen in Duchenne. And this really, really troubles me because I can't fathom any reason why this is needed less. I can only fathom reasons why it would be needed more, if I'm honest. So at the minute, the onus is on you as families to lead that and say to the medical team, this is what I need. If you are lucky, and there are some services with psychologists embedded in them, then you will probably have a psychologist that you will not know, and even if you don't see them, they will be sat in the background helping your team to think about how they meet your needs. A huge amount of work that psychology does is indirect. A huge amount of work, so it's not about sitting in front of a family and doing therapy, it's about supporting the team to meet your needs as a family. But if you don't have a psychologist, then you may find that the medical practice feels a bit less person-centered. It's not their intention, it's just they're not trained and they're not necessarily given the space to think about this because they're pacing through families so quickly. So an enormous part of my job would be to do that. In terms of crisis support, I will outline some of the sources of support that are available at the end, but just to be aware that in terms of a crisis, the first source of support is always your GP. And you can contact your GP at any time of day or night. You won't get your GP, but you can get a GP. And actually, if you were feeling really, really distressed emotionally, you can absolutely call 111. And they will offer, like you would call them if you were worried about your child because they had a temperature or whatever. You can call them about psychological distress. They are there for that too. But a lot of people don't realise that. And then obviously there's more generic services like the Samaritans. And then there's helplines, which aren't counselling, but are advocacy services, like Muscular Dystrophy UK run one, Together for Short Lives run one. And I think the really key question at diagnosis is, what do you have to do right now and what can wait? I think when you're feeling overwhelmed, and somebody asked me this morning about what do you do when your drug's full? And we didn't get to talk about it as much as I would have liked, but what I definitely said a bit, and I'll say again, is there's only so much you can do. If your drug's full, it's full. And there's not a magic strategy that's going to make that easier. If you just feel like you can't cope with anymore, and then something else happens, and it's too much. I guess one of the strategies that you can use, which is not a magic bullet and is not going to fix this, but might help just a teeny bit, is to think, what do I actually have to do today? And what do I actually have to do this week? And when you're feeling really, really overwhelmed, trying to break down the problem into its smallest step is a really, really useful strategy. And it's a useful strategy for you, but it's also a useful strategy to model for your children. So I'm not going to talk about this a lot, but just in terms of adjustment, I guess there are a range of symptoms that we would say are totally normal when you're adjusting to news. And that would be things like sleep difficulties, forgetfulness, anxiety, cheerfulness, anger, a change in appetite, a need for control, relationship difficulties. And we also had somebody pointed out this morning, which was really a miss, it should definitely be there, physical symptoms. And that could take a range of symptoms actually, headaches, tummy aches, pain. And these are, I would say, fundamentally normal responses. If you're adjusting to something, then your worldview has been challenged. So we all go along in life and we believe we understand what's going to happen. We have a set of beliefs about the predictability of the world, about the predictability of our hopes and our dreams. And essentially, we believe that we've got some control. We believe that we can hope things and that it'll probably happen. And we need to believe that, don't we? Because actually, it'd be very hard to live a life where you didn't have any sense of control. But often what happens when you have some really, really difficult news is that sense of control and that sense of, I know my world and I'm in control of it, is derailed. And you have to find a way of getting your train back on your track again. And you have to find a way of saying, well, this is how I'm going to live my life, even though some of the stuff I thought was true is not true anymore. And that's incredibly difficult. Like, as just a fundamental psychological task, that's actually extraordinarily hard. And that's why people often get these symptoms. And I guess my take-home message with this would be that these are not abnormal responses, these are normal responses. You're not going mad. And often, when I work with parents, one of the biggest fears, there's two fears that they often say to me. One is, if they're feeling this very strongly, they often say to me, I'm really frightened, I'm going mad. And one of the first things I would say is, you're absolutely not going mad. You're just trying to find a way of holding steady when life has done something very, very, very unfair to you. The other thing that families say is, I've just got to keep the lid on it. I can't go there. I can't allow myself to feel any of these feelings, because if I go a little bit, I'm not sure I'll come back together again. And again, as a psychologist, I would say, you know yourself best. And I wouldn't want to tell you what the right or wrong thing to do for you was, because what do I know? But I would say that you will go back together again. You will. Humans are incredible. Parents are incredible. What you will do for your children is what, you know, and I'm a parent, what we'll do for our children is incredible. So you might lose it for a while. Honestly, you might find it really hard to just follow normal daily routines, but you'll find a way through. And if you are struggling to find a way through, there are sources of support. It's not as good as it should be, but there are sources of support, and I'll talk to you about that at the end. So the standards of care doesn't talk about that stuff. That was me. The standards of care does talk a bit. I'll tell you where the standards of care does really beautifully in terms of psychosocial support is it starts to articulate some of the needs for the children in particular, and I guess this is one of the interesting things, because the standards of care has obviously recently been updated, but actually the psychosocial elements haven't had much of an update because there isn't that much new research. But what they do highlight is that we know is that people living with Duchenne have a higher chance of learning and behavioural difficulties. And that presents itself in different ways. So we know that there's a higher rate of autistic spectrum disorder. There's a higher rate of a diagnosis of attention deficit. And there's a higher rate of a range of various learning difficulties. And we don't really know why. We've got a few ideas. Some of that will probably be related to the altered rates of dystrophin in the brain. But again, the exact mechanisms for that are still unknown. But some of that will almost certainly also just relate to the psychological challenge of coping with the physical impact of Duchenne. And some of that relates to steroids. And again, what the standards of care do define helpfully is a recognition of some of the impact of steroid medication in terms of children's behaviour. And what we might see around increased episodes of anger, a difficulty regulating their emotions and regulating their behaviour. So I might have a sudden urge. So if we had a seat here which was on wheels, honestly, if I sat on, you know, like office seats, if I sit on one of those, it doesn't matter if I'm teaching. Honestly, it's a miracle if I can get through that session without feeling the urge to just shoot along on the wheels. I just love it so much. I really do. Now, I overcome that urge because the front part of my brain, the prefrontal cortex, allows me to go, that's not the right behaviour for this setting. Don't shoot up and down on your wheels. Just sit steady and look professional. But that takes ages for that to develop. We don't actually, our prefrontal cortex isn't fully developed until we're in our mid-20s. So children don't have it very well at all, which is why you can time out a 1-year-old. They're still going to do it if they want to do it. They literally do not have the cognitive capacity to withhold the urge to do something. They think, I want that chocolate cake. And it doesn't matter if you've told them 800 times. They see it, they go for it. They can't stop themselves. The part of their brain isn't developed. And we know that some of that regulation, that ability to regulate your desire to do stuff, appears to be affected when kids are on steroids. But we don't really know how. But there are some very real behavioural consequences, and there's some more extreme and rarer circumstances where children have more extreme reactions to steroids and adults. But it's really important to know that most children do not have these difficulties. So whilst we're talking about a higher rate of autistic spectrum disorder and ADHD, it's still the case that most children don't. So what I would say and what standards of care says, and it's really important, is if you are concerned about your child's development or learning in any way, please do ask for a referral. And this is one of the areas, there's psychology support's woefully inadequate, but this is one of the areas where you should have a better stab at getting access to somebody. You should find that you can access some neuropsychology, either from a neuropsychologist or from a clinical psychologist, or possibly an educational psychologist. Into late adulthood, or sort of late ambulatory phase, the standards of care, again, talk about the needs, essentially, the psychological needs at that time. And they focus on the importance. I think the standards of care, it's true to say, focus on the importance of screening and monitoring. I mean, that's the take-home message. We need to be monitoring. We know that this stuff, people are at higher risk, so we need to monitor it. That's essentially what it says. So they focus on the need to keep monitoring. And I think that is important because some cognitive Some cognitive difficulties won't present themselves until children are slightly older, because they might be, if they're concerned with a function that children wouldn't demonstrate till they're older anyway, you won't know that they're there. Does that make sense? So there are some things that children only start to do cognitively, intellectually, when they're in late childhood or early adolescence. So you don't know that they can't do it until they're there. So ongoing monitoring is really important. And they talk about, standards of care talk about setting goals for the future and how important that is, how psychologically important that is. And I'm going to talk a bit more about that in a minute. And what they highlight, but not in any detail, so I'm going to talk about it in a bit more detail, is the challenge of coping with loss of physical independence that comes with the late ambulatory phase. And I've added in the challenge of coping with the loss of physical independence whilst needing more autonomy. Because this is the psychological challenge for a teenager with Duchenne, is that their physical independence is decreasing at a time when their need for autonomy is increasing. And how do we find a way of meeting both, taking that both into account and meeting both needs? And we can, and you can, but it's tricky. So this absolutely isn't in the standards of care. This is entirely me. Autonomy is so important. So standards of care highlights autonomy, but it doesn't talk about it in any detail. And I think often people aren't clear what autonomy really means. So autonomy is the ability to act of your own volition. It's the ability to do something that is important to you. It is in no way reliant on physical independence. And this you can see why this really matters. So we know, now more or less every theory of resilience or psychological well-being will talk to you about the importance of autonomy. And this is just one theory. I happen to cite this theory because it's the theory I used a lot of in my doctorate thesis. But there's way more out there. But Decky and Ryan, they try to understand humans' basic needs. And they said there's 3 basic human needs that we all have. And they said relatedness, autonomy, and competence. And those of you who saw me earlier, you will have heard those things come up in the models of resilience. Resilience has come later, but these ideas have been important for a long time. And autonomy, in Decky and Ryan's theory, autonomy is absolutely the ability to do what you want to do. So from their point of view, you could make a choice to be absolutely 100% dependent on somebody and be acting with autonomy. If you say to yourself, it's important to me that this person helps me with my self-care, if you make a choice for yourself that that particular person does it, and perhaps you choose that somebody does it over the use of technology. So sometimes obviously there's stuff that can be done to support people to live independently. It can be done through technology or could be done through a person. If somebody chooses that a person does that, they are still acting with autonomy if they have made a choice. But often services don't understand that distinction, and there can be a focus on, well, we must help people to be independent. And it's not, we shouldn't be thinking about independence, we should be thinking about autonomy. We should be thinking about what that young person wants. And this comes a lot around transition, because again, there's been this there's this emphasis on, at transition, you go into adult services and we need to talk to the young person. We don't talk to their parents anymore, we talk to the young person. And I've seen this in clinics. And actually, from an autonomy point of view, you say, no, that's not what you do at all. You ask the young person, who do you want me to talk to? Do you want me to talk to you, or do you want me to talk to your parents? And if you want me to talk to your parents, fine. I'm supporting your autonomy. So this distinction is important, but it's poorly understood. And then alongside that, there's relatedness and competence. And relatedness is that sense of social connection, which again is pulled out in the standards of care, is recognised as being really, really psychologically important. And then the competence, that sense of I've got some agency and I can do something. So there's something about really having choices and having control and being able to do stuff and doing stuff that you can fail at, which is psychologically hugely important. You have to have challenge. We all need psychological challenge. In fact, one of the key interventions one of the most evidence-based interventions for depression, just depression most generally, not kind of in relation to coping or adjusting to anything, is going out and being engaged in exercise or going back to work. It's really difficult. The emphasis, the kind of political emphasis on getting people with depression back to work is really, really troublesome. It's come about for a good reason. It's come about because we have really solid research evidence that suggests that when you're low, if you're engaged in meaningful activity, it reduces your lowness. There's something about having a purpose, feeling like you've achieved, which is really good for mental well-being. Obviously, inevitably, that has been turned into something slightly different, which is what we've got now. But at its core, there was something good about that as an idea. So into the early non-ambulatory phase. Now, this is a key psychologically challenging time because it requires a very significant adjustment again. And I think having worked with parents, what parents have said to me on many occasions is that that for a while they could almost forget. So they had the diagnosis, and whenever they would have to go to clinics, it would be stirred up again. But in between that, for a long time, their child was very well. And the differences and the difficulties they were having were probably quite subtle. And so they could almost forget. And this is a really key time when they can't forget, because there's a very visual cue. But it doesn't have to be a negative time in the way you might think. And my experience is that children and young people view it very differently to how their parents view it. And of course, there's as many children's ways of viewing it as there is adults. And so there's the whole range of experience, isn't there? We all view things differently. But I think a lot of this is about whether you're meeting their autonomy needs, whether they've got control and choice. And some of it's about what support you've got. Clearly, if you're able to get adaptations in your house early on, if you've kind of got the financial ability to do that, that's going to make this an easier process than if you're having to cope with a child going off their legs and still being in a house with stairs and not being able to access the bathroom. So this stuff matters. But planning seems to be key. Conversations about transition. I'm not going to talk about transition a lot because I know you've got a separate session on transition, but we know that transition conversations should start at the age of 13 or 14. I mean, actually, I would argue earlier, but that's what it says in the standards of care. And again, depending on your service will depend on how good they are at this, but please do ask if they are not talking to you about transition. And by transition, I mean support. There's lots of different transitions, but in this context, I mean transitioning your child's care to care that's provided by paediatrics through to care that's provided by adult services. If they are not talking to you about that, they should be. And I would really, really encourage you to ask them, when are you going to start talking to us about this? Because it matters, and it's the change in the way services are set up for children and services set up for adults is quite stark. So in some parts of the country, you'll have lifespan services, which is best practice. We don't really have a gold standard yet. We're working on one, actually. But if we were, when we do, it will say that lifespan services are the best, I'm sure. Maintaining connections. So the transition between adolescence and young adulthood is a key one, obviously. What's really key and what young people often talk about is that school gives them friendships. They have all that kind of, school is all about friendships. And if school doing its job properly, your child will have good friends and will be supported. Often university, similarly, slightly more problematic, but often that will be encouraged. There can be a real drop-off point if they've gone to higher education, post-higher education, or when they leave school at 18 if they go into the workplace. Because often workplaces don't really have it as an aim to establish friendships. So there's been some research with young men with Duchenne, and that this has been talked about as a really key time, and a time when often they struggle a bit with some of their friendships because obviously their disability is increasing often quite significantly at this point. And they're not engaged in anything in a day-to-day activity that facilitates friendships. So it's really, and obviously you can get around that, it just takes thinking. So it's well worth having that in your mind and planning for it and encouraging them to plan for it. And support and information about managing relationships, and in particular intimate relationships. And this is so under-talked about. David Abbott, who's here today, he's not talking about this, I thought he was. He's talking about palliative care, but he's done some really, really interesting research on this, as has, I think, John Hastie, who's also here, I believe. And it was well worth looking at. How do we talk to young men about the relationships they want to have? How do we talk to them about meeting their needs, their intimate relationship needs? This is an area that we shy away from, and we're doing everyone a disservice because we all have the same human needs. So what and when and how to tell your child. So again, the standards of care talks about this, and basically the standards of care says, this is not going to come as any surprise, openness is important. And so I'm not going to talk about this a lot because I know you've had parallel workshops on it. But I guess I would say, from my point of view, this is a hugely personal decision. And every family has to work out when it's the right time for them. And whilst the literature says very clearly that children tend to know more than they've been told, they tend to do better when they can have open conversations, they often worry about stuff that they haven't been told about, and they're constantly listening to information and putting stuff together, so they tend to have ideas, whether you've told them directly or not. There's a really robust literature that talks about that. I still think that you know your child best, and children hit their readiness for information at very different times. And it's not as simple as saying, well, at 10 they need to know this, and at 14 they need to know that, because one 14-year-old needs to know a lot, everything, and another 14-year-old probably doesn't. So I tend to think about it as around around how can we follow their lead? You know, if they're asking questions, then that's a cue that they're ready for some additional information. It is important to make it explicitly clear that they can ask questions, though, because my experience clinically and the research suggests, and this is mostly what I do when I work with young people, I mostly do this, I support them to understand their diagnosis. And so I'm often in a situation where parents are saying to me, no, you can't tell them. And I'm sitting with the child, and the child knows and is saying, don't tell them I know. I can't tell you how often that happens. And the worry there, of course, is that they are holding a fear that they can't talk about. And they don't talk about it because they love you so much. And I see this most in loving, tight, close families, where parents love their children so much that they're just going to do the best they can to protect them for as long as they can. And the children love their parents so much that they're going to do the best they can to protect them for as long as they can. And the danger then is that the child is left holding anxiety and worry that they can't talk about. So there is something about being explicit. And as I said, I can't go into any more detail about that because we'll run out of time, but there is another session on it. I've written a leaflet that you can get on Muscular Dystrophy UK's website, specifically on this topic. I've also written another version of the same leaflet on Together for Short Lives website. In terms of psychological well-being, there's something about living by your values. Standards of Care talks about goals, which are really important. Values are bigger than goals, though. Values are what matters to you most. Who do you want to be? When you get to the end of your life and you look back on your days, what are you going to say to yourself was important? What are you going to say was, what kind of mother did you hope you were? What kind of father did you hope you were? And thinking about your child, what kind of qualities do you hope to equip them with? What kind of adult do you want them to be? And these are big questions, but they're important questions. And so in terms of thinking about how you support your child going forward, but also how you look after yourself, I would say it starts with knowing what matters to you. Because we're all different, and there isn't a right or wrong, is there? One person's values will not be somebody else's. And that's okay. But what does matter is that you're living a life in accordance with yours. And this is so important to me, because what this says to me is it doesn't matter the level of physical disability you face. If you know what matters to you in your heart, the kind of person you want to be, you can live a meaningful life because you can live in accordance with your values. So this for me is everything. And there's lots of work, and this is when you can do this, absolutely do this on your own, but if this is something you really struggled with, this would be the kind of thing you might go and see a psychologist and they would support you to think about. I'm really sorry I even have to put this slide up there, and I realise for some people it might be painful to look at. It's really, really important that we don't confuse palliative care with end-of-life care. Palliative care and end-of-life care are not the same thing. Palliative care should be about living with uncertainty. So I work in a palliative care team, and when I explain what my team does, I would say it's about living with uncertainty. It's a team here to support you to live with uncertainty when you don't know what's going to happen. And that's important because then the focus of palliative care should be about how do you live with your values? How do you live according to your values when there is enormous uncertainty about what might happen? And there's a thing to say about planning for emergencies. So often people worry that if they talk about this stuff, it will somehow make it real. And this is really powerful, this fear of talking about stuff, somehow making it real, or somehow meaning that you think that you're accepting it. Talking about it won't change what's going to happen. It's just words. So I can stand here and I can say, my daughter's going to die today. That made me feel a little bit sick saying that. But I can say it because I know it's just words. It won't make it happen. It's just words. But for some of you, you probably wouldn't be able to do that. You would probably just say, I can't do that. And that's because we all believe that words matter. And words do matter. They do. But they are not magic. You saying something will not make it happen. But it's really, really hard sometimes to hold that in mind, and that's often a barrier for access, for having some of the really difficult conversations. But what I would say is this is about giving you, and most importantly, your child control, and making sure that they get to live in accordance to their values and your values and wishes. And these conversations are so much easier to have at times of wellness, and have them and then tuck them away and then don't have to think about them. And some of the limited research that's been done with young adults has said they really appreciate that. They want to know it's been done and they don't have to think about it. And then they want the service to respect that and not bring it up every 2 minutes, which I've got to say we've got to get better at. And it doesn't mean you haven't lost hope. Because I think there's always hope. I think, although I work in palliative care and I work in oncology palliative care as well, we see extraordinary things every day. Of course we do. I sit on intensive care with children who have defied the odds in the most extraordinary ways. That happens all the time. So I think there's always hope. And I think engaging and planning for difficult days doesn't mean you give up hope. It just means you do both at the same time. Self-care, so I would say, if you want to do any of this stuff, if you want to support your child to live by their values, you have to look after yourself. And that's really, really tricky. Because most of us feel guilty, most of us, our centre of our world is our kids, so we will always put their needs above our own. And that's lovely, that's what makes us parents. But you can't if you put their needs above your own every second of every minute of every day, you will not actually put their needs above your own, because you won't be able to, because you're only human. You can only do so much, all of us can. So there is something really important about looking after yourself. And finding what helps you, and this is a really personal thing, like what helps one person doesn't help the other. This is the kind of stuff that comes up in the literature, so exercise, seeing friends, talking, distraction. You're not really allowed to put wine. I used to always put wine, but it's deemed a bit unethical now. But obviously it's whatever works, isn't it? It's whatever helps you. But make sure, if you're feeling full, if you're feeling like little things are sending you over the edge, if you're feeling like, have you ever had it when you get into the supermarket, just the decision over what to buy for tea is overwhelming, and you think, this isn't normal, like I'm just trying to pick tea, but this feels like the most impossible decision. These are signs that you're at capacity and that you need to look after yourself a bit. And so I'd really go back to, what are you doing to look after yourself? And that's not selfish, that's about putting your child first, because if you look after yourself, you can look after them. The other thing is, that's about modelling self-respect. That's about modelling looking after yourself. And if I asked you what your value was for your child and how they would approach their own self-care, I very much doubt there would be anybody who would say, well, I really hope my child never looks after themselves and they always do everything else for everybody else. You wouldn't want that for them. And yet you model that on a day-to-day basis. So that putting yourself, and I'm not suggesting you're not looking after you, but I just know that you'll be looking after your children, so I don't even need to say that. But you probably won't look after yourselves in the same way, and I'm urging you, please find a way. And you're going to feel guilty, probably. And we're probably not going to get over that. You're probably just going to have to do it and carry guilt with you, because that's the parental experience. Siblings' needs. The standards of care talks a bit about siblings' needs. I guess the challenge of siblings is quite extraordinary, I think, and underlooked. They have the normal tasks of development, of growing up, all the normal challenges. It's hard being a teenager, isn't it? God, I wouldn't go back to being a teenager for any money. It's hard being a teenager. It's hard going through a transition from primary to secondary school. It's hard enough. But they're having to do that whilst manage the uncertainty of what's going on with the person they love, more than anything, with their best friend, who they hate 70% of the time, but who they love more than anything. And often they'll be managing, as they learn more, they'll be managing their own grief around the relationship they thought they were going to have, the things they hoped to do. Particularly if we're talking about an older sibling with a younger sibling, because they'll have had dreams and thoughts about what they thought they would be doing. And often the reality, the cold, hard reality of this is that they'll often be going through all of this and they'll be doing it with less parental input than they would like. Because of the best will in the world, you can't be in more than one place, can you? You just can't. It's not about how much you want to, it's not about how much you love them, it's just you cannot both be in the hospital with your child for their 6 monthly checkups and at home taking your other child to their PE day. You just can't. The sibling will experience compromise, they will. And I don't think there's a way of dressing that up. I think there's little things you can do. You can try and make sure that you give them extra time. And I'd advocate, try and find time, one-to-one time for each of your siblings, all of your children. I'd say this anyway, though. I mean, this is true for families, full stop. We're not good enough at it, but it's really important. Children really need one-to-one time with their parents. But I think also it's just about saying it's okay. So, you know, like I would say to you, it's okay to feel what you're feeling. It's about saying to siblings, it's okay. It's okay to be fed up. And I'm really sorry I'm not doing as much as I can for you. But it's not because I don't love you. I love you so very much. And just bring it into the open and say it so they don't think it's about them. Because that's the problem. If you don't, then sometimes they think they've done something wrong. And listening, it's all about listening and consistency. I guess the other thing is guilt pushes us to do things that perhaps we wouldn't do otherwise. And don't be afraid to be consistent and still have the same normal expectations because they still need them. So in summary, the text talks about focusing on cognitive and language development and the need for screening that. And so if you do have any concerns, if you think your children's language is delayed, if their play isn't quite where you would expect it, that would be a possible sign of some learning difficulties. Then please speak to your neuromuscular team or your GP. It talks about psychological well-being in terms of emotional well-being. It talks about behaviour learning. And it talks about social skills and social engagement. So I'm really quickly going to go over this. So signs of depression. This is just taken, I'm not going to read it. It's just taken from the NHS website. Any of us can experience depression. This is not something that only happens to certain people. Any of us, if we have enough thrown at us and we don't have the right support, any of us is vulnerable. And if you feel that you're having any of these difficulties, please seek help because it doesn't have to be that way. And when you feel depressed, often it feels like it does have to be that way because you can feel, by definition, you feel quite hopeless. But things can be different. In children, I will talk about this a bit. So children you might say are sad, they might say they're sad and depressed, but usually with children you see it in other ways. You're more likely to see that they're irritable, that they're clingy, they might have difficulty sleeping. And then you might have specific thoughts around, they might talk about not feeling worthy or important, their eating might change, they might describe feeling empty, and in late childhood, early adolescence, you may see things like self-harm. Signs of anxiety, again, this is all available from the NHS website, but I guess what to say is anxiety is tricky, anxiety comes out in sneaky places. Anxiety doesn't tend to get better on its own. If you're struggling with anxiety or somebody you love is struggling with anxiety, I would really urge you to get help quickly. Anxiety is one of those things that it does tend to grow and develop, and it just doesn't fix itself. But there is really good evidence-based psychological therapy which is extraordinarily effective for anxiety in particular. In children, again, it's very similar to low mood, but you might see increased clinginess, you might see being really rigid, you have to follow the same routine exactly. You might see nightmares or difficulties of eating and concentration. We all have ups and downs, but if you find yourself or somebody you worry about having this consistently, then please seek help. And your GP would normally be the first point of contact for that. And psychological therapy on its own, or sometimes in conjunction with medication, can be really effective. And that's what I would say. I would say, do it because you deserve to. Get help because it helps, and it could be really effective. But more importantly, get help because you deserve to. You deserve to feel happier than that. If you're struggling, please don't do it on your own, because you don't have to be on your own. There is help out there. And just having somebody sit there with you and listen can make the most extraordinary difference. In terms of crisis support, I said I would touch upon this. Please, please, please know that you can call 111 or the Samaritans if you feel really like you're in crisis and you need help straight away. Because feelings come and go. It doesn't matter how bad you're feeling in any given moment. Your feelings will change. The intensity of those feelings will change. And sometimes it's just about surviving and hanging in there. Have I got like -1 minute? Yeah, sorry. Told you I'm useless. So there's different psychological therapies, which I'm not going to be able to talk about in detail, but I will be around afterwards. Cognitive behavioural therapy, very strong evidence base, the most NHS-funded service. If you go through improving access to psychological therapy service, there's a link at the end of this, they would probably offer you cognitive behavioural therapy. It's very good for anxiety in particular, it really is very good for anxiety. It's not my favourite approach personally. I use more acceptance and commitment therapy, which is a third wave cognitive therapy. The difference between the two, in cognitive behavioural therapy, I'm walking down the street, I see Sarah. Sarah doesn't wave at me. I walk home and I go, oh, she doesn't like me. That's because I didn't handle that situation at that party very well. I was a bit rude. And then I feel low and sad. So the way I thought about the situation affected how I feel. Then when I go and see Sarah at the school pickup, because she's another mum, I'm a bit nervous and I perhaps don't go and say hello. So then she doesn't say hello to me because I was a bit unfriendly to her. And so we don't have a friendship anymore. And I feel a bit low about that too. So in cognitive behavioural therapy, they target the thought. They say, okay, so how about if you walk down the street and when Sarah didn't wave at you, you just thought she didn't see me? Then you're not left feeling low. You're not questioning your friendship. You're not questioning your worth. When you see Sarah at the gates that day, you go, hi, Sarah, how are you? And your friendship's maintained and you're feeling good. So cognitive behavioural therapy says the way you think matters. And so the main target for intervention is changing and challenging your thoughts. There's a role for that, for sure. As that clearly is really important. Acceptance and commitment therapy comes at it from a slightly different viewpoint. It says the way you think about stuff, sure, that matters. But it says it's really hard to change your thoughts. We all have thoughts. And so if I asked you to think about a pink elephant, and then I asked you to stop thinking about a pink elephant for a minute, you would all think about a pink elephant. But probably in the last 24 hours, you didn't think about a pink elephant. The act of trying not to think about it made you think about it. So acceptance and commitment therapy says, there's a bit of a limitation with just standard cognitive behavioural therapy. So in acceptance and commitment therapy, they say, hang on, how about you say, I know that sometimes I'm going to have some thoughts, but I'm not going to change what I do because of them. I'm just going to bring them along with me. So that insecure thought, that guilty thought, I'm not going to get rid of it. I'm not going to argue with it. I'm just going to say, come on, this is how I want to live my life. You can come along for the ride. So rather than stopping life and trying to argue with your thoughts all the time, in acceptance and commitment therapy, they say, don't stop life. Keep going with life and take the thoughts with you. And that sucks. That sucks because it means sometimes you're going to feel anxious and sometimes you're going to feel low and sometimes you're going to feel guilty and sometimes you're going to feel angry. But that's the way it is. So ACT really lends itself to living with difficulties, I guess, because it says, okay, we're going to have to find a way of living with it and this is crap, but we're going to help you to just live with it anyway, because what else can we do? So it's not about saying it's okay. It's absolutely not about saying it's okay, but it's just saying, what else can we do? And I'd rather you lived a life in accordance with your values than spent your whole life stopping, trying to debate something that you can't change anyway. Family therapy is another way of conceptualising the problem, which can also be really, really useful. Those are the resources. This will be on the website, I think, so you will be able to access them, including how to access psychological support, both for children and adults. Thank you very much for having me. It was really nice to come and speak to you.